I'm Peter Block in Chicago at the AHA annual meeting for On the Scene, and with me is Deepak Bhatt, an old friend and colleague from the Brigham and Women's Hospital in Boston. Deepak is the semi-rock star of this meeting. The Reduce It trial probably will be the breakthrough trial in this meeting that Deepak presented, and I'm not going to take any more wind out of his sails. So Deepak, tell me about Reduce It. What was the trial like, and why does this become really important?
So first of all, I've always considered you a rock star.
Yeah,
I
well,
should just
thanks.
put that out there. But Reduce It was an 8,000 patient study, and to get into the study, patients had to have elevated triglycerides, and what that meant in terms of what we actually ended up doing was triglycerides between 135 and 500 milligrams per deciliter, and the average triglycerides ended up being 216 milligrams per deciliter.
So let me interrupt, because in fact triglycerides has always been sort of an arm that we've had trouble with.
Absolutely. I mean, I think triglycerides were in and then they were out. Maybe they're back in again. Hopefully they're back in. But yes, for a while it seemed like it was worth measuring. Then people, I think, stopped measuring it. But it's pretty clear now from Mendelian randomization data, for example, that triglycerides are not only a risk marker, but seem to be a causal risk factor. Not quite as potent as LDL. You actually need to reduce triglycerides a lot, if you believe the Mendelian randomization data that I do, to get the same benefits that you would get by reducing LDL by less. But nevertheless, risk factor, risk marker. And we wanted to get patients that were well treated with statins. The average LDL coming into the trial was 75 milligrams per deciliter. So well treated, still have elevated triglycerides, and additionally have cardiovascular risk. And by that, I mean folks that have stable coronary artery disease, stable cerebrovascular disease, or stable peripheral artery disease, or diabetes with at least one additional cardiovascular risk factor. So that's the population.
Treated with what? Because this is the interesting thing.
Yes, so the randomization is to icosapent ethyl or placebo. And what icosapent ethyl is the way we use it here is 4 grams per day, 2 grams twice a day, but 4 grams a day. And what icosapent ethyl is, icosapentaenoic acid, that is a highly purified version of that. So folks might be familiar with omega-3 fatty acids, DHA, EPA. If you go to a nutraceutical sort of place, that's what you typically get, a combination of EPA, DHA. What this is a high dose of highly purified EPA.
Okay, so we don't have a lot of time, so tell me about the outcomes, because they're very impressive.
Absolutely. So the primary endpoint, 5-point MACE, so cardiovascular death, MI, stroke, hospitalization for unstable angina, coronary Revasc procedures was significantly reduced by 25%, an absolute risk reduction of 4.8% over a median of about 5 years, and it was highly statistically significant.
So tell me, I mean, you're saying percentages, give me the real data. What are the actual numbers of the outcomes?
Yeah, absolutely. Let me go actually to the endpoint that some people really want to focus on, which is cardiovascular death, MI, stroke. That is what some call the triple ischemic and so forth. And there was a 26% relative risk reduction and a reduction of about 20% to 16-ish%. So over 5 years, pretty substantial risk reduction. The other sorts of benefits that were seen in this trial, and I'm speaking only of adjudicated and pre-specified endpoints, were a 20% reduction in cardiovascular death. That also included significant reductions in sudden cardiac death. It also included reductions that were significant in cardiac arrest. There were also reductions that were significant in stroke, a 28% reduction in stroke. This might hurt us actually as interventionists, but a significant reduction in elective revascularization as well as emergent or urgent revascularization.
If we do our job right, we don't have a job. I've always said that. So this is a great thing. I mean, you take some of this stuff, you live forever. But does everybody have to take this?
No, I mean, we studied a specific population, and we screened about 19,000 to get about 8,000, so about a 43% rate of capturing patients who were screened. So that's pretty good. Most trials, you screen a bunch of patients, you end up randomizing a relatively small proportion. So I think the results are pretty generalizable, but again, these were patients that we wanted well treated on a statin, LDL between 40 and 100, and triglycerides between 135 and 500. So that's the population we studied. Might it be beneficial in patients with higher LDL? Probably. No reason to think it wouldn't be, but that's not what we studied.
Okay, well, thanks, Deepak. I think people really should take note of this study. This is a study that is going to make a big difference in outcomes over time. Highly purified omega-3, if you want to think of it that way, and hopefully not that expensive and great outcomes. Thank you,
I
Deepak.
should mention, though, it is a prescription medication.
Oh, absolutely. No, I
so,
get that.
Yeah,
Thanks, Deepak.
absolutely.